بسم الله الحمد لله والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم. Inshallah, today we will continue on antimicrobial chemotherapy, and today inshallah we'll discuss antiprotozoal drugs, drugs that use for treatment of protozoal infections, and mainly we'll talk about antimalarial drug and drugs that use for treatment of amoebiasis and gardiasis. Protozoal diseases include malaria, which is caused by Plasmodium species, falciparum, ovale, fevax, and malaria. Amoebiasis that caused by Entamoeba histolytica, and gardiasis that caused by Gardia lamblia, and leishmaniasis which caused by Leishmania species, visceral leishmaniasis and cutaneous leishmaniasis, trypanosomiasis that caused by Trypanosoma species, and trichomoniasis which caused genital infection that caused by Trichomonas vaginalis. First, we'll talk about malaria, and we know that there are 4 different species of Plasmodium falciparum, which cause the most severe infection, cerebral malaria, and Plasmodium vivax that cause more benign disease, as do Plasmodium malariae and ovale. Plasmodium vivax and ovale have relapsing forms that are hard-boiled in the liver, so they cause the relapse fever because they can be dormant on the liver, and so that can cause relapsing malaria. They called due to their liver stage. Plasmodium ovale is mainly confined in Africa. This is the lifespan of the malaria parasite Plasmodium. You know it already in the microbiology, but the drugs according to this lifespan for this parasite protozoal, we have drugs that which can affect on an erythrocyte form. These drugs include artemisinin and the chloroquine, quinine, mefloquine, and pyrimethamine. These drugs which are effective in treatment of the clinical features that associated with the erythrocyte forms of the Plasmodium. And we have drugs that are effective against the gametocyte form, such as the primaquine, which is effective in the prevention of transmission because the female mosquito take these gametocytes, and then by preventing this, we can prevent transmission of the disease. Also, primaquine effective against the exoerythrocytic forms, the liver form, so also it can prevent the relapsing forms of malaria. The clinical features of malaria, acute falciparum malaria is potentially fatal. The complication of malaria can result in cerebral malaria, hypoglycemia, pulmonary edema, and acute renal failure. Chronic repeated infection can cause splenomegaly and progressive anemia. Antimalarial drugs can be classified into the following. First, tissue schizonticides, which act on the exo red blood cell forms in the liver. They act on the liver forms of the parasite and protozoa. And we have blood schizonticides, which attack the parasite in the red blood cell, so they terminating the clinical features such as the fever and other malaria symptoms, because these symptoms are occurred due to the presence of the parasite in the RBCs. Also, we have gametocytes, which destroy the sexual forms of the parasite in the blood. So they are very effective to prevent the transmission, because the transmission is occurred due to the these sexual gametocytes. Also, we have hematocytes, which kill the dormant hematocytes that for the Plasmodium vivax and Plasmodium ovale in the liver. So they are anti-relapse drugs, prevent the relapse or the recurrence of the malaria attack due to the dormant parasite which occur in the liver. Last, we have sporontozoites, which interrupt the development of sporogenic phase in mosquitoes. So also they are very effective in prevention of the malaria transmission. We find that the anti-malaria drugs act at different stages of malaria parasite life cycle. This including the mosquito and in the human both in tissue or in the RBCs. First, in mosquito, they called sporontocytes. This include primaquine, progranulin, and pyrimethamine. In human, the tissue schizonticides include the progranulin, which act on both in mosquito and in tissue as tissue schizonticides, and pyrimethamine, primaquine, and the tetracycline. Clinical malarial, these drugs act as blood schizonticides, affect the parasite protozoa on the RBCs, while the protozoa on the RBCs. This include chloroquine, quinine and quinidine, mefloquine, sulfadoxine and pyrimethamine, fancy that, halofantidine and tetracycline. Anti-malarial drugs can be used either prophylactically or to treat the established symptoms, curative, or to prevent the transmission by directing the drugs against the gametocytes or mosquito agents. First, prophylactically, they are used to prevent the clinical attack, either in a form of supportive prophylactic, which the use of blood schizonticides to prevent an acute attack, such as the chloroquine and quinine, or causal prophylactic. This is the use of tissue schizonticides to prevent the parasite from establishing the liver, to prevent the relapsing of the which caused due to the liver forms. Or they can be used curative to support as a supportive treatment for an acute attack. Usually this occur with blood schizonticides to treat and establish symptoms, or to prevent the transmission. This is for eradication of the infection in mosquitoes using gametocytes or sporontocytes. Now we'll talk about some of these anti-malaria drugs, and first we'll talk about chloroquine. Chloroquine is one of the drugs that used extensively in treatment of malaria in the last decade, but nowadays it's use reduced or minimized due to the presence of chloroquine resistant malaria. Due to resistant, nowadays seldomly used in treatment of malaria. Chloroquine is a potent blood schizonticides, so that is effective in treatment of the clinical features of malaria. Chloroquine acts by inhibiting the digestion of hemoglobin by the parasite, decreasing the amino acid supply necessary for the parasite viability. It's also inhibit alkene polymerase, so it's toxic for producing toxic effects for the parasite by inhibiting. We'll see this mechanism. The parasite digests the host cell hemoglobin to obtain the essential amino acids. This digestion will result in digestion بتاع الهيموجلوبين will result in excess of heme which result from digestion of hemoglobin. The process releases a large amounts of heme which is toxic to the parasite. So the parasite should convert the heme to hemozine which is less toxic to the parasite. Chloroquine inhibit the conversion of heme to hemozine, which is less toxic to parasite. So the accumulation of heme will have a toxic effect on parasite inside the red blood cells. To protect itself, the parasite ordinarily polymerizes heme to non-toxic hemozine, which is sequestered in the parasite food vacuole, الفجوة بتاعت الطعام بتاعت الباراسايت. Chloroquine prevents the polymerization of hemozine, so the accumulation of the heme result in lysis of both the parasite and the infected red blood cell. Resistance result from enhanced efflux of parasite vesicle leading to increased expression of transporter B glycoprotein. As I mentioned, nowadays there is a resistance to chloroquine which results in expression high expression of B glycoprotein which efflux يعني bump out the chloroquine after it enter RBCs inside الباراسايت inside RBCs. after الكلوروكين enter inside الباراسايت is especially in the food vacuole of the parasite. Then there is an expression due to the expression of B glycoprotein which efflux or pump out the chloroquine outside the parasite. So the resistance can develop by this manner to the chloroquine. We have actually two pump molecules called Plasmodium falciparum multidrug resistant one. This is which pump out. This is a chloroquine. This is a parasite vacuole, the whole food vacuole, and this is a plasmodium inside the RBCs. And this is the hemoglobin, which is degraded to heme, which as I mentioned, toxic, so that the chloroquine prevent the conversion of heme to hematozine, which is less toxic to the parasite. Chloroquine after entrance inside the parasite and inside the food vacuole, it can be pumped out by carrier molecule called Plasmodium falciparum multidrug resistant 1, which pump out the chloroquine, efflux out the chloroquine, evacuate the chloroquine from the food vacuole. So the resistance can develop by this manner. Also, there is a carrier molecule also called chloroquine resistant transporter, also can pump out the chloroquine after the entrance inside the parasite. Chloroquine is known as also by its effect in treatment of rheumatic arthritis. It's called it's belonged to a drugs that called disease modifying anti-rheumatic drugs, and this is unrelated to antiprotozoal effect of chloroquine. It's completely disregarding the pharmacokinetic of chloroquine. Chloroquine is completely absorbed orally, concentrated in parasite RBCs. Chloroquine released slowly from tissues and metabolized in the liver, excreted in urine 70% unchanged. Elimination of chloroquine is slow. This is because chloroquine is one of the drugs that having a large volume of distribution. The chloroquine volume distribution is about 15,000 liter in a human that weighing 70 kilogram. So it's have a large volume of distribution, so that its elimination is very slow. The adverse drug reaction of chloroquine can cause nausea, vomiting, dizziness, blurred vision, headache, and urticaria symptoms. Long dose can cause retinopathy. This is due to the chloroquine can be accumulated in the retina due to its large volume distribution. It also can precipitate it or deposit it on retina. So the long doses, long-term treatment of with chloroquine can cause retinopathy. Also, the bolus injection of chloroquine can cause hypotension and dysrhythmia. Chloroquine safe for pregnant women. This is a summarization of some of these adverse effects of chloroquine: GIT disturbances, skin rash, headache, and blurred vision. We have quinine. Quinine is a blood schizontocide like chloroquine. It's active against the erythrocytic form of all species of malaria, including Plasmodium falciparum, which is resistant for the previous one, chloroquine. Quinine acts by inhibiting parasite heme polymerase, and we know that this enzyme, the polymerase, is very important for the parasite because the heme is toxic, so it should be converted to less toxic compound. By inhibiting this polymerase enzyme, this will lead to accumulation of heme, and which the heme have a toxic effect, have a toxic effects on the parasite itself. Quinine depresses the myocardium. This is because or due to its effect on a sodium channel, because it can inhibit the sodium channel like its isomer endoisomer called the quinidine. Quinidine ده اصلا classified التصنيف بتاعه في الفارماكولوجي anti arrhythmic drug, class 1 anti arrhythmic drugs, because it inhibit or it block a sodium channel in the myocardium. Also quinine to a degree less than its isomer quinidine can also depress this in the myocardium. Quinine also mild oxytocic effect on the pregnant uterus. Oxytocic effect معناها it can have the same effect like an oxytocin, which contract the uterus. So oxytocic effect means contracting effect on a pregnant uterus. Slight neuromuscular blocking action also maybe due to the sodium, its effect on sodium channel, have a sodium neuromuscular depolarizing effect. And also quinine have a weak antibiotic action. Quinine given orally in 7-day course or by slow IV for severe Plasmodium falciparum infection, metabolized in the liver, and the half-life time of quinine is 10 hours. Resistance is conferred by increased expression of a B-glycoprotein, which pump the drug out of the parasite. Nowadays also there is quinine resistant, but not extended like chloroquine resistant. The adverse drug reaction of quinine, bitter taste is one of the famous things. The bitter taste of quinine, alkaloid with a bitter taste. Poor compliance due to this bitter taste. It also can cause nausea and vomiting, and the concentration more than 30 to 60 millimole per liter can lead to synconis. Synconis is the symptoms, and the name came from a plant called Cinchona species because the quinine is obtained from the bark اللحاف بتاع النبات called the cinchona, is a cinchona species. فالسينكونيزم كل الكوينيدين and drugs that obtained from this plant can cause characteristic symptoms called synconism, which represented as nausea, dizziness, headache, tinnitus, especially the tinnitus, and blurred vision. High doses of quinine can cause hypotension, cardiac arrhythmias, and delirium, CNS effects, and coma. Hypoglycemia also can result from quinine. This is due to that the quinine stimulates the insulin secretion. Blood dyscrasis and hypersensitivity reaction also can occur as adverse effects associated with the quinine use. Black water fever is a fatal condition in which acute hemolytic anemia is associated with renal failure, which can occur due to the quinine use. Now we'll talk about another drug called mefloquine. Mefloquine also is a blood schizonticides that active against Plasmodium vivax and Plasmodium falciparum, but not effect on hepatic form of the parasite. It only acts on blood as a blood schizonticides. It have no effect on the liver form or hepatic form of the parasite, so that it cannot prevent the relapsing malaria. Also mefloquine inhibit heme polymerase, the same mechanism. Resistance has occurred in Southeast Asia. There is a resistance for this drug mefloquine. Adverse drug reaction include GIT disturbances, transient CNS toxicity, result in a form of dizziness, confusion, dysphoria, the opposite of euphoria, and insomnia. Mefloquine may provoke neuropsychiatric disorder, may stimulate or may induce a neuropsychiatric disorder. Mefloquine contraindicated in pregnant women. Now we have halovantrine, also blood schizonticides agent that active against strains resistant to chloroquine, pyrimethamine, and quinine. Halovantrine هو effective in the strains that are resistant to chloroquine, pyrimethamine, and quinine. There is a cross-resistant falciparum infection occur nowadays to this drug, halovantrine. Adverse drug reaction of halovantrine including abdominal pain, headache, transient increase in hepatic enzyme, cough, pruritus, and lengthening of QT intervals. So it can cause or can lead to susceptible people اللي عندهم cardiac arrhythmias that which called torsade point arrhythmia. Halovantrine may cause hemolytic anemia and convulsions. Reversed only for the infections that caused by resistant organism. Due to its adverse effects نحن فقط بنخليه resistant malaria that is not treated by chloroquine and or quinine. So in this case we can use the halovantrine due to its adverse effects. The antifolate المستخدم that used for treatment of malaria, we have two types of antifolates, those sulfonamides and sulfons, which compete with the para-aminobenzoic acid, as we talked before when we talk about antibacterial drugs. And type 2 antifolate اللي هم البايريميثامين والبروجوانيل، وديل اللي هم inhibit dihydrofolate reductase enzyme. Antifolate drugs have slow actions against erythrocytic forms of parasite, blood schizonticides. Pyrimethamine is used in combination with either dapsone, this is not commonly used in our country, but with sulfadoxine. This is a commonly used اللي هو الفانسيدار sulfadoxine plus pyrimethamine used for treatment of malaria. Sulfonamides and sulfons are active against the erythrocytic forms of Plasmodium falciparum. Pyrimethamine and pyrimethamine, as I mentioned, pyrimethamine and a sulfadoxine combination called Fansidar is used for chloroquine resistant malaria. The pyrimethamine and proguanil are absorbed orally slowly regarding their pharmacokinetics. Adverse drug reaction for antifolate drugs, especially the large doses of alpyrimidine and dapsone, this can cause hemolytic anemia. Also, agranulocytosis, eosinophilia, and alveolitis, inflammation with the alveoles, alveolitis. These are adverse effects of this combination, especially in large doses. In high doses, pyrimidine inhibit mammalian dihydrofolate reductase, resulting in megaloblastic anemia. In low doses, it affects the parasite, but in high doses it can affect the mammalian cell, so that it can inhibit the dihydrofolate reductase, so this can result in megaloblastic anemia. Resistance also arises from a single mutation in the gene encoding the parasite dihydrofolate reductase in the parasite البروتوزوا. there is a mutation حصلت طفرة فيه، فدي أدت للresistant against the antifolate, especially the drugs that inhibit the dihydrofolate reductase. فبالتالي will be اللي هو less sensitive or unsensitive or resistant to this drug. We have البرايموكوين، and البرايموكوين characterized by إنه هو effective as against liver forms, liver hematozoites, active against the liver hematozoites, producing radical cure of parasites which have dormant stage in the liver, especially اللي هم البلازموديوم فيباكس and plasmodium ovale اللي هم عندهم relapsing form, because they can have an effect or they can be dormant in the liver. Primaquine also has a gametocyte action, most effective for preventing the transmission of the disease, because a mosquito take from the blood these gametocytes. Then the cycle, there is a part of the life cycle of the parasite inside الموسكيتو واللي هم بيستخدم فيها الجاميتوسايتس، وبالتالي البرايماكوين can prevent الترانسميشن عن طريق انه هو having a toxic effect on الجاميتوسايتس. Combined with sometimes البرايماكوين combined with الكلوروكوين، والكلوروكوين is a famous blood schizontocide، فبالتالي can treat the clinical features أو clinical symptoms of malaria. The mechanism of action of primaquine unknown. Resistant to primaquine is rare. The adverse drug reaction for primaquine include GIT disturbances. In large doses can cause methemoglobinemia with cyanosis. Also, primaquine can cause hemolysis in patients with glucose 6-phosphate dehydrogenase deficiency. Its metabolites have greater hemolytic activity. Glucose 6-phosphate dehydrogenase deficiency is one of the genetic or inherited abnormalities that occur with this enzyme, and this enzyme is very important for the reduced form NADP to be reduced in reduced form, mediated through this enzyme, glucose 6-phosphate dehydrogenase. So the deficiency, the one who genetically deficient in this enzyme will not or will respond to the stress, oxidative stress, more than the others, because because the primaquine is one of the drugs that having an oxidative stress. This oxidative هو oxidative agent. فإن case of المرضى اللي عندهم جلوكوز 6 dehydrogenase deficiency، البرايماكوين ممكن يعمل لهم هيموليتيك انيميا. ليه؟ لانه الاكسيديف او الاكسيديشن او الاكسيديف ستريس that produced by this drug cannot be managed نتيجه لانه البيشن عندهم هم deficiency في جلوكوز 6 phosphate dehydrogenase، فبالتالي هم كان result this can result in hemolytic anemia. We have al-artemisinin and al-artesunate, and both of these are derived from plant herb called al-artemisia. Artemisinin is poorly soluble in water, but al-artesunate is having a good water solubility, so it can be available as oral and dosage form. It fast acting. Both of them are fast acting blood schizonticides. Uh, they are effective in treating acute attack because they are blood schizonticides, so they are effective for treating an acute attack, including chloroquine resistant malaria. They are effective for the chloroquine resistant malaria. Al-artesunate, as I mentioned, was water soluble derivative, and artemisinin also have activity and better absorption. Both of them have a better bioavailability. Uh, these drugs damage the parasite membrane by carbon convert free radicals that generated due to the breakdown of alpherous protoporphyrin 9 or covalent alkylation proteins. Due to this generation of free radicals, these drugs will lead to a toxic effects provided by these free radicals نتيجة البريك بتاع الفيروس بروتوبورفايرين 9 و this can lead to the kill or damage of the parasite. They are readily absorbed and widely distributed. Regarding the pharmacokinetic, the half-life time of al-artemisinin 4 hours, al-artesunate 45 minutes, while al-artemisinin having a half-life of 4 to 11 hours. The adverse drug reaction for these drugs include transient heart block, decreased neutrophil count, and brief episodes of fever. They are neurotoxic in animals. No report of resistance for these drugs. Now we'll talk briefly about the resistance for this malaria. There is about 90% of malaria deaths occurred in sub-Saharan Africa, so it is one of the tropical disease that have serious effects on these tropical countries, including Africa. The factor contributing to resistant malarial morbidity and mortality is increased resistance of falciparum, Plasmodium falciparum, to chloroquine and sulfadoxine. Artemisinin compounds produce a very rapid therapeutic response, active against multi-drug resistant Plasmodium falciparum, well tolerated by the patient, inhibit gametocyte carriage, no resistance detected. So nowadays they are the drug of choice. Now malaria treatment, you will find one of these products, artesunate or artemisinin, are used in combination according to the WHO recommendation. Artemisinin cure falciparum malaria in 7 days. Now this is the WHO recommendation regarding malaria. WHO recommends that all countries experiencing resistance to conventional monotherapies, chloroquine, quinine, should use combination therapy preferably containing artemisinin or artesunate اللي هم لابد يكون فيهم واحد من these derivatives. These include WHO recommend the following therapeutic options: artesunate plus amiodarquine. This is a drug that act in the same manner like chloroquine. Or artesunate plus sulfadoxine pyrimethamine اللي هو الفانسي ده. This is used as a first line treatment in Sudan according to the previous malaria protocol. Artesunate plus mifloquine, areas with low or moderate transmission. WHO recommend في الareas اللي فيها low or moderate malaria transmission recommend الارتسونات plus الميفلوكوين. Artemisinin plus lumefantrine واللي هو عندنا known as quartam brand name. Also this is one of the combination that recommended by the WHO. And last or before last, amiodarquine plus sulfadoxine pyrimethamine and Now we'll talk about amoebiasis, which is a common protozoal infection. This infection occurs when the patient ingests a cyst. The cyst then, when reach the intestine, it will form trophozoites. Uh, then the trophozoid in the intestine can penetrate the small wall of the intestine. Uh, the presence of trophozoites in the intestine can be treated by luminal amoebicides such as albaramycin and iodoquinol. Then after penetration of the intestinal wall, the protozoa can multiplicate within the colon wall, and also this can result in systemic invasion, which can transmit it to the liver. Uh, the presence or multiplication of the trophozoites within the wall can be treated by systemic amoebicides such as chloroquine and dihydroimidine. Also, the presence or the person can be infectious regarding amoebiasis due to the presence of the cyst of the parasite in the colon, and the presence of the cyst can be eradicated or eliminated or killed by antiprotozoal drugs such as metronidazole and tinidazole, which can prevent also the transmission and can treat the mixed amoebicide that consists of luminal and systemic activity of the parasite. Then the patient will be infectious when the cyst discharged with feces, so that can be oral fecal transmitted due to the contaminated food or substances due to the presence of cyst with feces. Uh, Amoebiasis, as I mentioned, produced by ingestion of the cyst of Entamoeba histolytica in the intestine. The cyst develop into trophozoites that adhere to the colonic epithelial cells by protein known as lectin. The trophozoid then lyses and the host cell and invades the submucosal, leading to the amoebic dysentery. The parasite may invade the liver, leading to development of liver abscess. Some individuals are carriers, infectious. They can infect others. They harbor the parasite without developing overt disease, but can infect others. Treatment of amoebiasis. The treatment of amoebiasis will be according to the clinical setting of the patient. If the patient suffers from asymptomatic intestinal infection, then the choice, the drug of choice is just a luminal agent, such as diloxanide, furet, oral iodoquinol, oral albaromycin, in which the dosage, diloxanide furet will be given 3 times daily for 10 days. Oral iodoquinolone will be given 3 times daily for 21 days. Oral paramomycin will be given as 3 times daily for 7 days. So that asymptomatic intestinal infection, just only luminal agent, one of these choices. If the patient suffers from mild to moderate intestinal infection, then metronidazole will be added to the luminal agent, one of these three. Metronidazole or oral flagyl 3 times daily for 10 days. This is plus one of the first choices اللي هم luminal agent diloxide furet or iodoquinol or albaramycin. If the patient suffers from severe intestinal infection, then metronidazole 3 times daily for day, also the same treatment like a mild to moderate for 10 days plus a luminal agent. If there is a hepatic abscess, maybe an extra-intestinal disease, then metronidazole will be given 3 times daily for 10 days without the use of luminal agent. Metronidazole, or brand name as Flagyl, will kill the trophozoid of Entamoeba histolytica but has no effect on the cyst. Effective against invasive amoebiasis but less effective against organs or organisms in the lumen of the gut. It damages the trophozoid DNA by toxic oxygen products that generated from the drug by the parasite. When the parasite metabolized the drug, this will lead to the generation of toxic product, oxygen product, that will damage the DNA of the parasite. Metronidazole pharmacokinetic, absorbed orally, have lifetime 7 hours. Also rectal and IV preparation in form of infusion, IV infusion, are available. Distributed in the body, most of the metronidazole will be excreted unchanged in the urine. The adverse drug reaction of metronidazole, including the metallic bitter taste, GIT disturbances, dizziness, headache, sensory neuropathy sometimes, and interfere with the alcohol metabolism, because metronidazole can cause a reaction that called disulfiram type reaction. Disulfiram type reaction. This happens when the metronidazole inhibits the metabolism of alcohol by inhibiting the enzyme alcohol dehydrogenase, which convert the alcohol to aldehydes, and the aldehyde convert the acetaldehyde to acetic acid in order to be excreted renally, so that this can lead to the accumulation of acetaldehyde. Acetaldehyde then can cause nausea and vomiting, flushing, headache. This type of reaction is called disulfiram type reaction, which can lead to undesirable symptoms that are associated with alcohol consumption. Alcohol content indicated in pregnancy. These are some adverse effects of alcohol: nausea, GIT disturbance, and metallic taste. We have diloxanide, which is a luminal agent. Diloxanide and diloxanide furet, effective against non-invasive intestinal parasites that occur within the lumen, non-invasive, that cannot cross or penetrate الintestinal wall. Has a direct amoebicidal action. Given orally, has no serious side effects. Now, lastly, we'll talk about gardiasis as also a common protozoal infection. Occur due to the ingestion of cysts, and then trophozoites can be found in feces. Infection occurs by the ingestion of cysts. If the cyst is contaminated with water or food, or with fecal oral route via hand or الفوميت سواء المعدات. in small intestine اللي هو الاكسايتيشن اللي هو الفري of the parasite from the cyst, that can lead to release of trophozoites. Then trophozoites multiply in the lumen of the proximal small bowel, where they can be free of attached to the mucosa by sucking disc. Incistation occurs as the parasites move towards the colon. The gardiasis is caused by protozoan Giardia lamblia and is characterized by GIT symptoms ranging from acute self-limiting watery diarrhea to chronic conditions that are associated with episodic diarrhea and occasional instance of the malabsorption. The parasite is similar to Entamoeba histolytica in that it exists in two forms: an actively motile trophozoid, usually confined to the upper small bowel, and cyst, which commonly excreted in the urine and result in infectious with gardiasis. Treatment: we have also the metronidazole. The adult dosage 250 milligram 3 times daily for 5 days. while البيتيادريك dosage 15 milligram per kg for body weight per dose 3 times per day for also for 5 days. Or we have also tinidazole, which brand name Fasigene, Pfizer, from Pfizer company, Fasigene. The adult dosage of Fasigene 2 gram once, while pediatric dosage 50 milligram per kg for body weight also once, and the maximum should not exceed 2 gram for the pediatric dosage. Side effects of tinidazole include or similar to metronidazole, but appear to be better tolerated and just as effective. The common effects include bitter taste, also like metronidazole, vertigo, and GIT discomfort. The drug should be taken with food to minimize the side effects. Also, the same can be done for metronidazole. If taken after food or with food, this can minimize or can reduce the side effects. I think that is all regarding antimicrobial, antiprotozoal drug. Thank you. Assalamu alaikum wa rahmatullah wa barakatuh.